So yes, like Judy said, I'm Dr. Gary Volkell. I am one of the neurologists at MedStar Franklin Square Medical Center. I'm the director of movement disorders at the hospital there. And without further ado, I'm going to kind of move along to make sure that we have time to answer some questions. The focus of the topic today are the non-motor symptoms of Parkinson's disease. It's a little bit impossible to talk about Parkinson's disease without also talking about the motor symptoms as well. So I'm going to touch on those, including a little bit of the treatment of it, because they are intertwined. We'll move along here. So just there we go. Just a really quick outline. These are sort of a little bit about what we're going to be talking about. I just want to start off with a little bit of a brief history because I always think that's nice, which is that Parkinson's disease gets its name from Dr. James Parkinson. He was an English surgeon and described this condition in his famous essay, An Essay on the Shaking Palsy. Originally it was called paralysis agitans. And later, a very famous neurologist, Dr. Jean-Martin Charcot, ended up renaming the disease Parkinson's disease in honor of Dr. Parkinson. So what is Parkinson's disease? It's a chronic and progressive disorder. It's caused by degenerative loss of dopaminergic neurons in the brain and characterized clinically by asymmetric Parkinsonism and a clear dramatic benefit from dopaminergic therapy. So yeah, what does all that mean? Really a lot of big words. So I like to just kind of talk a little bit about the anatomy of Parkinson's disease, just so that we kind of have a shared understanding of what's going on in the brain. And then we'll talk about the symptoms that it causes, a little bit about diagnosis, but we are going to talk about the non-motor symptoms because it's a really important part of Parkinson's disease that I feel like often doesn't get the spotlight. So I mentioned that there are all these dopaminergic neurons before. So dopamine plays a big role in Parkinson's disease. It's a hormone or a neurotransmitter, a chemical in the brain. We use it in our brain and our whole nervous system to basically send messages. It does a lot of things. We use it for a lot of different things, including it's part of the motivation and reward or pleasure pathways. And it plays a really big role in movement, which makes sense because Parkinson's disease is one of the main movement disorders that I take care of. So where is dopamine? Well, it can be found all over our body. When we're talking about Parkinson's disease, I'm usually focusing specifically on where it is in the brain. And it's specifically in a part of the brain called the substantia nigra. I'm going to move my cursor around. I can only see Judy and Michael's head. Are you able to see my cursor? Okay, if you can, okay, perfect. Most of the brain cells that make dopamine, the majority of them are in this area called the substantia nigra, which is highlighted in red over here. And that's where a lot of the dopamine is made. And what happens is once it's made there, it's able to leave the substantia nigra and it goes to these other structures in the brain made up of brain cells called the basal ganglia. And they're kind of highlighted in this, I don't know, magenta color here. You can see the substantia nigra here and then these other structures here. And these parts of the brain, these structures, these basal ganglia, play a really big role in helping people have normal movements. And once, so the dopamine goes to these areas, when it's done, it gets used up and it gets recycled. And so the question is, what happens in Parkinson's disease? So in Parkinson's disease, there is this abnormal protein that develops called alpha-synuclein. We don't quite know why that happens, but basically proteins misfold. They get folded and turned into the wrong shape. And then they kind of deposit all over the body, including the substantia nigra. So substantia nigra literally translates to black substance, which is, it gets its name because the dopamine and the different chemicals that are part of the creation and destruction of the dopamine are kind of this dark color. But in Parkinson's disease, when alpha-synuclein deposits in different parts of the body, but specifically in the substantia nigra, it starts to kill off and destroy those brain cells that make dopamine. And then people, when this is happening, they have much less dopamine to work with, and they start to experience symptoms of Parkinson's disease. So over here on the right, you can actually see this is a cut of a part of the brain, and this really dark lines, these are the substantia, this is the substantia nigra. You can see it really does look like it's a black color, and you can see in somebody with Parkinson's disease on the right, it's much lighter, and that's because those brain cells making dopamine are disappearing, they're dying. Who gets Parkinson's disease? It's predominantly, it affects men more than women, although it still affects women. It happens most commonly in older age, people greater than 60 years old. Like I said, men have a higher chance of developing Parkinson's disease than women. I won't go too much on that because I want to move us along to to some of those symptoms that we're going to get to, those motor and non-motor symptoms. Okay. So like I said, the focus for today won't be so much on the motor symptoms, but I think it's still important to talk about them because even though they're only one set of the symptoms, they're the ones that most people are familiar with. And the four of them are bradykinesia, which is a slowness of movement, rigidity, which is usually stiffness around different joints, tremor, which is kind of a shaking or movement pattern like this, usually around a joint. It's oscillating, it's pretty rhythmic. And then postural and gait impairments or instability. When we call these symptoms together, they're called Parkinsonism. And there are different things that can cause Parkinsonism. The most common thing is Parkinson's disease, although there are other movement disorders that can cause Parkinsonism, and there are some medicines that can cause Parkinsonism as well. I highlighted bradykinesia, so to speak. It's a different color. It's in black as opposed to white here, because in order to have Parkinsonism, you need to have bradykinesia and at least one of these three other things. You can have all of them, but you don't need all of them. And when somebody has bradykinesia and one of these three other things, it makes us think the person has Parkinsonism, and then we try to figure out why they may have Parkinsonism, and most of the time it's because that person has Parkinson's disease. Okay, so let's talk a little bit about non-motor symptoms. So before I was saying how dopamine does a lot of stuff in our bodies. The main thing that you see when we're talking about motor symptoms is that when you have less dopamine, you end up having these abnormal movements. You have slower movements, you have the stiffness, you have tremor, and you can have gait or postural instability. But as I said before, we know that dopamine does more than just help with movements. It's part of the mood pathways, things like the reward, pleasure pathways. And it does a lot more too. And certainly when people have less dopamine, we start to see other symptoms that don't just affect the movement. So motor symptoms, whenever I say motor symptoms, I'm talking about these four symptoms here. A non-motor symptom is anything that doesn't really affect our movements. It's everything else that can happen with Parkinson's disease. Kind of important too is that even though most of the time when people are coming to me and asking, hey, I'm worried because I notice that I have a tremor, or I'm worried I'm not walking the same way. They're often noticing the motor symptoms first, but the non-motor symptoms often start affecting a person years, sometimes even decades before the motor symptoms present, so that they can start earlier, and their impact is usually even more significant than the motor symptoms, depending on where somebody is in the stage of their disease. One of the tricky things I'll talk about when we're talking about treatment is that, again, we focus a lot on treating those motor symptoms to help people move better. Unfortunately, the medicines and treatments that we use for motor symptoms can actually make the non-motor symptoms worse. And I will say that again later, because I think it's actually one of the most important parts of treatment is the fact that treating one set of symptoms can actually make another set of symptoms worse. Okay, so I'm going to kind of go through a few of the different types of non-motor symptoms, and then we'll talk about treatment and management of some of these symptoms. And I'll try to be as timely as I can to finish in 30 minutes so we can have some time for questions as well. So in terms of non-motor symptoms, there are neuropsychiatric symptoms. So these are symptoms that affect somebody's mood, their motivation, their behavior. So people with Parkinson's disease can develop things like depression. And that can be depression because anytime somebody's diagnosed with a chronic disease, like Parkinson's disease, it can cause somebody to be upset or down. But also, we know that dopamine plays an important role in people's mood. So having less dopamine can contribute to depression as well. So it can be more than one reason in Parkinson's disease why somebody could be depressed. It can contribute to things like anxiety. It can also contribute to things like apathy, which is like a loss of motivation. People feel less motivated to get up and go about their day. They may lose interest in the things that they normally enjoy doing, hobbies, things like that. Can lead to impulsivity, especially some of the treatments that we use. People can become much more impulsive, including things like they may start gambling their money away. They may start going on spending sprees, things like that. And then it can also lead to something we call psychosis. So psychosis is when somebody's thinking or beliefs don't match up with the rest of reality. I know that we probably say that people are like that when we don't agree with them, but this is more clinical, right? So that would include things like illusions. So an illusion is when you see something and you confuse it for something totally different. So like if you left a sweater on the couch and you looked at it and for a moment you thought it was a cat, and then you took a closer look and you said, oh no, that's just the sweater. That's an illusion when you confuse something for something else. Versus a hallucination where there's nothing on the couch, there's no sweater, but you see a cat there that's not there, or you hear a cat there that's not there. That would be a hallucination when there's nothing there, but you're seeing something that isn't there. There's also delusions. And a delusion would be we call a fixed false belief. So believing that somebody's out to get you would be like a paranoid delusion, or believing that you were created king of the world or something like that. And it would be like a delusion of grandeur. And some of these things too, especially the depression and anxiety, can fluctuate with how well the medicines are working. We'll talk about with the treatment, but the medicines aren't always at a constant level in your body. They go up and down. They kind of have peaks and valleys. So sometimes, depending on if the medicine is working really well or not working really well, people can be more or less anxious, for example. It's also cognitive symptoms. So these are the symptoms that affect the way somebody thinks. That would include memory loss and dementia. So as I'm going through these, a lot of whenever I see a patient, I always ask people if they're experiencing some form of these things, and frequently either the patient or somebody maybe that person brought with them will ask, does that mean that my loved one is going to experience all these symptoms? It doesn't mean that you're necessarily going to experience all these symptoms, but they're all possible. The one thing I will say though is, for the most part, memory loss or dementia is something that's guaranteed to happen at some point if somebody has Parkinson's disease for long enough. So we're talking on the order of years. Sometimes it can happen earlier, 5 years, but sometimes it's 10 years, 20 years into the disease process, people will start to have at least some form of memory loss. It could just be as simple as word finding difficulty or inattention. There's also something called bradykinesia, which is a slowness of thought, where that person knows exactly what they want to say. It just takes them a little bit longer to think about it and then talk about it. And unfortunately, oftentimes, somebody will try to help them and they'll try to guess what the person is saying, which can be frustrating for the person who's trying to say it, and also frustrating for the person who's trying to anticipate what the person may say. But that it can also happen as one of the cognitive symptoms. And there's dysautonomia. We'll talk a little bit about these. Sometimes it's also called autonomic dysfunction. So our nervous system has a lot of different components to it. One of them is the autonomic nervous system. That's the part of the nervous system that does all the stuff you don't have to consciously think about. So for example, you don't have to think about, well, I just ate some food, okay, gut muscles, it's time to digest my food, right? You never have to think about that. While some people are able to really control their breathing or their heart rate, but most people don't, right? It just happens. You don't have to think about it. It just happens. Sweating, right? These are things that we don't have to think about. Our autonomic nervous system does them automatically, right? But when the autonomic nervous system isn't working well, which can happen in Parkinson's disease, we get these other symptoms. So there's something called orthostatic hypotension, which is a low blood pressure when changing positions. So for example, if somebody goes from lying down or sitting down to standing up, normally our blood pressure remains constant because our autonomic nervous system makes sure that all the receptors and mechanisms that keep the blood pressure stable stay stable. But when the autonomic nervous system isn't working correctly, that may not work as well. So going from lying down or sitting down to standing up may drop our pressures. When that happens, people can feel like they're going to faint or they may actually pass out. Constipation, which I'll talk about on a separate slide, it can be a big one, which can lead to things like loss of appetite. Urinary incontinence is another one. Sexual dysfunction like reduced libido, erectile dysfunction. You can also get sweating and dry, flaky skin. You can see here in this picture, as well as drooling. When people are swallowing less because the autonomic nervous system is slower, the saliva can pool in the mouth as well. Here's just another, there's a picture. Unfortunately, it's all these really medical terms here, the different parts of the autonomic nervous system that may not function as well. Just to talk a little bit more about the autonomic nervous system, it's kind of broken up into three parts within it. There's the sympathetic nervous system, which is within the autonomic nervous system, which is kind of the fight or flight part, right? That's the thing that gets your heart racing. It gives you the energy you need to escape from a bad situation or deal with a bad situation, versus the parasympathetic, and that's kind of the opposite. It's the rest and digest system, right? It's going to help you break down food, calm everything down, right? And these two things work kind of in opposites to make sure that you need a little bit of each at different times. And then finally, there's the enteric nervous system, which is it's kind of a third part. It's sort of like a separate nervous system for your entire gut. Sometimes it's called the body's second brain because it has a ton of basically nervous cells in it. And it really helps with everything from digestion to moving everything through the gut. So obviously when this is not working well, it's going to cause some serious problems, like, for example, constipation, like we talked about. And that is something that most people will experience at some point in the course of having Parkinson's disease. It can be one of the first signs that people experience well before any of the motor symptoms, can even precede the disease by 20 years. It's 3 times more likely to occur in somebody with Parkinson's disease than somebody without Parkinson's disease. And when people have constipation, it tends to be more severe in Parkinson's disease than not. That can lead to things like, decreased appetite, nausea, indigestion, bloating. And it can cause some serious problems, like making somebody end up having to go to the hospital due to complications of the constipation, where they're not able to pass things through their entire GI tract. Okay. There are other things that can occur as well, like altered senses. So that can be things like the sense of smell and taste can be changed, or people can lose those senses. And in fact, a loss in the sense of smell can also come before the disease of the motor symptoms, I should say, by many years. People can experience pain as well as fatigue. And to talk a little bit about pain, almost everyone with Parkinson's disease will report some type of pain at some point. Can be anywhere in the body. One of the most common sites would be at the shoulder. So sometimes when people are first presenting with stiffness or rigidity or pain, they may think that they have a frozen shoulder. They're not able to move that shoulder as well. They may go to their primary care provider or an orthopedist first, but it could actually be the onset of something like Parkinson's disease. These kinds of pains can fluctuate with medicine. So when we talk about treatment, the medicine that we take can go, and again, in peaks and valleys. So sometimes when the medicine wears off, people can get cramping or stiffness, or sometimes when people are on too high of a dose, they can get too much movement, which can cause cramping and stiffness, right? We walk a little bit of a tightrope with this, and that's a common theme that I always bring up with patients when we're talking about Parkinson's disease. There can be other causes of pain as well. So there's central pain. So central pain is the idea of the nervous system itself. There's just an aspect of how it's interpreting pain that's been altered. So people with Parkinson's disease, the way that their brain and nervous system recognize and understand pain may not be working the same way and make people experience pain. As well as, when you have stiffness at the joints, it's going to worsen things like arthritis, which everyone gets. And that can lead to things like back pain, joint pain, right? People can also have this condition called dystonia, which is why I have the feet, which show that kind of twisting, pulling of the muscles. That can happen because people are on too low of a dose of medicine, where the medicine's wearing off and the muscles are cramping up. It can also happen if you're on a very, very high dose of medicines that we usually use to treat motor symptoms. That last thing at the bottom there is neuropathic pain. So that would be things like nerve pain, which people can experience for all different reasons. The most common reason people get neuropathic pain would be diabetes or chronic or excessive long-term alcohol use, and can happen from other things too, like vitamin deficiencies and things like that. Turns out just having Parkinson's disease can cause a little bit of neuropathic pain, pain from nerve injury. Sleep disorders would be another phenomenon that we see. Include things like insomnia, sleepiness, fatigue, which we talked about. There's this thing called restless legs syndrome, which people can experience. You don't need to have Parkinson's disease to have restless leg syndrome or vice versa. The two are separate diseases. It just so happens that people with Parkinson's disease can get restless legs, which usually involves an uncomfortable sensation of some kind that affects people, usually at bedtime when they're relaxing. Something called periodic limb movements of sleep, which is similar to restless legs, although it usually happens while people are asleep, as opposed to restless legs, which happens while people are trying to go to sleep. Something called REM sleep behavior disorder, or RBD, which involves things like people having really vivid, lifelike dreams, often nightmares. They're usually action-packed. People are punching, kicking. They may call out in their sleep. They may hit a bedfellow if they share a bed with somebody. They can fall out of bed and really hurt themselves. So that can be pretty serious. And it's certainly something that we try to address as well, because REM sleep behavior disorder can also come before having some of the more common motor symptoms of Parkinson's disease. Again, just because you have one doesn't mean you'll have the other, but they tend to run more together than some of these other things. There's also this thing called a sleep attack, which tends to happen when we're giving people medicines to treat their Parkinson's disease. When they sometimes at different doses of the medicine, it can cause sudden sleepiness. So it can be pretty dangerous if somebody's trying to drive a car. It's something that you want to be aware of if you're on a medicine that may cause you to become very drowsy and fall asleep all of a sudden. So things with diagnosis, for example, this is a clinical diagnosis, Parkinson's disease, and it usually comes from asking a lot of questions like how many non-motor symptoms are you having, and then also doing an exam with the person to see if they're having those motor symptoms that we were talking about earlier. It may be something that a primary care provider may be able to diagnose. I always recommend, if you have a suspicion that you or a loved one has Parkinson's disease, to definitely be seen and evaluated by a neurologist, preferably a movement disorder specialist, because those are the experts in this disease. My preference is if I am a patient, I want to be seen by the person who knows how to treat what it is that I may be suffering from. But part of a visit with getting diagnosed with Parkinson's disease will include giving a good medical history to the doctor, doing that physical exam. And usually that alone is enough to make the diagnosis. We usually don't need anything like blood work or head scans. I'll show you that there are a few of those things as well, and not to dwell too much on these, but in some cases, there's this special test called a DAT scan over here, a DAT scan. DA stands for dopamine and the T stands for transporter, or dopamine transporter. And the idea behind that is it's a special this thing called ioflupine. It binds, it's like a little radionucleotide that you get a dye injected into you, and it binds to all these transporters that are moving dopamine around in the brain. And somebody with a disease like Parkinson's disease, or one of the diseases related to it, it's going to appear abnormal. They're going to have fewer this molecule, this ioflupine, it's not going to bind as strongly. So you can see over here, there's like this nice robust comma in this picture here, which is where the ioflupine is binding to those dopamine transporters. And then over here, you can see it's significantly less like that. And that's because this person's brain is losing dopamine. It could be that they have Parkinson's disease. It could be that they have one of the atypical forms of Parkinsonism, which can also cause loss of dopamine. This can be a really good test if we're not sure if somebody has something like Parkinson's disease or a medicine that they're taking is causing them to have symptoms of Parkinson's disease, even though they don't actually have that. But getting a test like this, I always tell people there's certain medicines that make the test no good. So if somebody is ordering this, you always have to make sure that you're not on any medicines that are going to make the test not work appropriately. I've seen quite a fair number of people who were told that they think they have, we're told, by a doctor, they think they have Parkinson's disease, and it's not somebody who's as familiar with this test. And then they go get this test, and it turns out that they're on multiple medicines that make it so that we can't even interpret the results anymore. So you don't want that happening. We'll talk a little bit about treating motor symptoms, because again, it's so important, but kind of the main therapy has been and still continues to be this medicine called carbidopa, levodopa, went by the old brand name Sinemet. What happens here is levodopa is the part of the medicine that gets turned into dopamine in the brain. And then our brain can use the dopamine as it normally would. Helps people have a improvement in their movement, their motor symptoms. The carbidopa, I like to think of it as like a suit of armor. It protects the levodopa so that it safely gets to the brain where it can get turned into dopamine. It's like a helper part of the medicine. And this can really help with a lot of the motor symptoms, but it's not constant. So at the very least, most people need to be taking this medicine at least 3 times a day to make sure they have good levels of the medicine in their body throughout the day. Over time, as the disease progresses, people lose more and more brain cells that make dopamine. So they need higher and higher doses of medicines like this, or medicines that help carbidopa, levodopa. So they may take it 5 times a day, sometimes even 7 times a day at higher and higher doses. And that's why when I was talking before about the peaks and valleys, if you're taking it multiple times a day, you may get like a nice peak as you're taking the medicine. As it wears off, it starts to come down again. You take your next dose. And that's why people can get fluctuations in their motor symptoms and as well as their non-motor symptoms. I won't dwell too much on some of the other medicines. I kind of broke them down by category here. One of the older class of medicines are called dopamine agonists. They are medicines that look a lot like dopamine. They're not dopamine, but they combine to dopamine receptors and basically help your body experience what would happen if they had dopamine, even if they don't. These come with some serious side effects, like we were talking about before. It can really worsen your non-motor symptoms. There's some others as well: COMT inhibitors, MAO-B inhibitors, NMDA receptor antagonists, things like that. I won't dwell too much on that because while these help with motor symptoms, it's not how we really approach non-motor symptoms. Because as I said before, what happens when we treat motor symptoms, it can make the non-motor symptoms worse. So this is my tightrope walker. I just realized she's wearing high heels. That would be too challenging for me. But a lot of times when we're doing medicines to help with motor symptoms, we kind of walk a few different tightropes. One is if you don't have enough medicine, you may not move as well as you'd like. People will move less. They'll have all those symptoms of Parkinsonism, the slow movements, the stiffness, the tremor, the gait and postural instability. But then if they get too much of the medicine, they have too much movement, which we call dyskinesia, where they may have rocking or swaying or even tightening of muscles, twisting, like those dystonias we talked about before. So those dyskinesias come from having too much of a dopamine in our system. So that's one tightrope we walk. The other one is as we increase the medicine, the motor symptoms may get better, but it may actually make the non-motor symptoms worse. So things like the dopamine agonists or even the levodopa can make things like sleepiness worse. It can cause those sleep attacks that I mentioned. It can cause worsening of hallucinations. It can cause worsening confusion. So all of these things all these non-motor symptoms can suddenly get so much worse while we're trying to treat one thing. So we really walk a tightrope to try to get right in the middle. And unfortunately, it's never perfect, but we try to do our best. To kind of finish up, how do we treat non-motor symptoms? Well, like I talked about, a lot of the medicines that I listed and I kind of blew past them, those are medicines that are really geared towards the motor symptoms. And a lot of times when we talk about Parkinson's disease medicines, we're often focusing on the motor symptoms. But that doesn't mean that we're not paying attention to the non-motor symptoms. Unfortunately, non-motor symptoms can be very difficult to treat. Like I said, they're made worse by the medicine we use to treat the motor symptoms. So just to kind of break some of this down, though, when we talk about psychosis, things like confusion, delusions, hallucinations, if that happens suddenly, all of a sudden somebody's doing great, they've had Parkinson's disease for several years, they're fine, and like overnight they totally change. That's not how Parkinson's disease works. Parkinson's disease is usually pretty slow moving. So if somebody changes overnight and they're delirious or confused, or their hallucinations are worse, or they never had hallucinations and now they suddenly do, oftentimes I find that it's due to another problem that's just making all the symptoms of Parkinson's disease worse. That can include things like a urinary tract infection, which it tends to be more common in women, but it's common in both men and women as we get older. And as silly as it sounds, people are familiar with urinary tract infections because they are common. When people are younger, healthier, they may not even know that they have a urinary tract infection, but unfortunately, as we get older, even a small infection like this can really, you don't even need to have Parkinson's disease. You can have hallucinations if you're perfectly healthy and you're an older person with a urinary tract infection, but it certainly makes things like the symptoms of Parkinson's disease way worse. People can have, if they're having difficulty swallowing from their Parkinson's disease, they may have accidentally had some go into their lungs and they could have a pneumonia. Maybe they're really badly constipated, like we were talking about. Maybe they had some changes in their medicines, which are causing them to act differently than they were before. Or they're on a new pain medicine, which is really sedating them. Right? These are all things that can happen. And I always check those things first. Those should always be checked first, because oftentimes if one of those things is present and you fix it, the person goes right back to where they were before, hopefully. But sometimes it's because we increase the carbidopa-levodopa, or a medicine that helps it. And when that happens, we may need to reduce it, right? And sometimes we can't change any of these things. There's nothing wrong with this, or we can't adjust the medicines. And we talk about getting a medicine that we usually call an antipsychotic, that can help reduce things like hallucinations and things like that. Dementia, there's still no good cure for things like dementia, whether it's due to Parkinson's disease or not. Sometimes we try these medicines like donepezil or galantamine or rivastigmine. Sometimes we try a medicine like memantine, but these tend to have very modest improvement. So there's no guarantee that something like that is going to help, but sometimes it can help a little bit. What about insomnia and fatigue? Well, just having a regular sleep schedule, like having a set bedtime and a set wake up time, avoiding naps during the day, that way you feel appropriately tired in the evening, can help. Sometimes stimulant during the morning, like drinking a cup of coffee in the morning, or a sleep aid at night, like melatonin, can be helpful. Melatonin is also one of the main things that we use to treat that REM sleep behavior disorder we talked about before, the punching, kicking, calling out in your sleep, falling out of bed from nightmares that you may be acting out. So that's also a great first line medicine for that. Another thing too for this is exercise. And we'll talk about that too, because one of the best things for Parkinson's disease is aerobic exercise. But as silly as it sounds with fatigue, when you feel like you don't have enough energy, exercise actually happens to be the best thing for fatigue, gives people energy back, and also helps with sleep disturbance from Parkinson's disease. It seems counterintuitive, but there's actually been a lot of studies looking at just this alone, and it's pretty remarkable. What about all that GI stuff we talked about earlier? Well, for constipation, same thing that you'd normally try for constipation was the same thing that we would try in Parkinson's disease constipation, making sure that you're drinking enough water, that you don't need to be drinking gallons of water, but making sure that you're not dehydrated, because our stool needs to have a lot of moisture for it to come out more easily, having fiber in the diet. There's certain medicines like that can help bulk up the stool, can help soften the stool, and even work as laxatives to help move the stool better. In certain extreme cases, when diet and some of these more mild medicines are not working as well, we even talk about suppositories or like an enema. And in very severe cases, sometimes people need to go into the hospital to have the stool removed for them by a provider, like a GI doctor. people with a swallowing difficulty, which can happen we talked a little bit about before, and it puts people at risk of having pneumonia. Sometimes just being put on a medicine like getting dopamine back will make the swallowing a little bit better. Sometimes seeing a speech or language pathologist can help modifying the diet to make it easier to swallow food and drink. And sometimes in very severe cases, we even talk about feeding tubes that can help. That thing before I talked about, the low blood pressure when changing positions, avoiding things that are going to naturally lower the blood pressure, like blood pressure lowering medicines, antihypertensives. Sometimes those need to be stopped or adjusted. Avoiding things like alcohol, which naturally lowers the blood pressure. And there's a lot of medicines in general that aren't even specific to blood pressure, which can lower blood pressure, like certain muscle relaxers and certain medicines that help affect our mood. Carbidopa, levodopa can lower our blood pressure as well. So again, it's another example of the medicine that helps with the motor symptoms, making the non-motor symptoms worse. Drinking plenty of water, right? Our blood is almost half water. When we're dehydrated, the water leaves our blood to go to the organs that needs it most. So drinking plenty of water will keep the pressures up, sometimes increasing. So I'm the only doctor that tells people that they may need to increase their salt in the diet. Compression stockings, exercise is going to help with things, not lying flat, having multiple pillows underneath the head while sleeping. That way, it's not such a big turn from lying flat to standing up. You're not going to get as big of a blood pressure drop. And just to briefly kind of touch on this and finish off here, when we're talking about disease management, I know I talked a lot about carbidopa, levodopa because it's such a big part of this condition. And, I talked a little bit about some of the other medicines, but we didn't even discuss things like surgical options because those, again, kind of really focusing more on the motor symptoms. But, typically we start people on a medicine like carbidopa, levodopa when their motor symptoms start. For a while, there was a concern that starting a medicine like this really early in the disease course would mean that it wasn't going to work as well later on. And that turns out it's not true. But again, over time, we may need to adjust a medicine like that to help manage the non-motor symptoms. And going through some of those other things, we're kind of managing the symptoms, those non-motor symptoms, as they pop up with treatments and therapies specific to those non-motor symptoms. Because again, just because it's possible to get those non-motor symptoms doesn't mean that everyone's going to get them. So we try to treat them as they arise. The most important thing with Parkinson's disease is aerobic exercise. The studies show doing at least 30 minutes, 3 days a week minimum. It not only helps slow down the rate of disease progression, make sure that Parkinson's disease progresses very slowly, because there's no cure, there's no way to stop it or undo Parkinson's disease. It's usually pretty slow moving throughout its course, but doing aerobic exercise has been shown to keep it moving as slow as possible. But we know that aerobic exercise helps with some of the non-motor symptoms, things like the blood pressure, sleep, fatigue, things like that. And any kind of aerobic exercise is good. Something that's going to get the heart racing is what they say. So whether it's running or a stationary bike or walking or Tai Chi, yoga, the no contact boxing, dance, things like that. These are some nice resources. There's a ton of, in addition to maps, which you're learning through here, there's a ton of different programs and different people all either researching Parkinson's disease or can provide resources about Parkinson's disease. Some references here. I know I went a little bit over the 30 minutes, but I wanted to know if anyone had questions now as well.
Okay, we ready for questions? So I've got some that people had submitted earlier. So the first one is, what is the most that exercise can accomplish?
Oh, that's a really good question. I can't say that I can tell you, percentages or exact numbers off the top of my head of how much it does for everyone. And everyone's going to be a little bit different, right? So no two people are exactly the same, and no two people's Parkinson's disease is exactly the same. So just because one person may have progressed faster than another person, or another person progressed slower, or one person had these symptoms and another person had those symptoms, you can't look at necessarily other people and know exactly how somebody else is going to be. And it's sort of the same with treatment. In general, the studies do show that aerobic exercise specifically, something that gets the heart racing, does seem to slow down the rate of disease progression. So they compared people who were doing aerobic exercise versus people who were doing either some other form of exercise or no exercise at all, or just kind of their daily routine. And the people who had been doing aerobic exercise tended to progress slower. They developed some of these other symptoms even later in their disease course. It has been shown to help with things like fatigue. It helps people get some of their energy back. It has been shown to help with sleep disturbance in Parkinson's disease. The other thing too, I didn't mention this with constipation, but moving around a little bit, so standing up, standing up, walking around, in addition to those other things, fiber in the diet, drinking plenty of water, and moving around actually gets the gut to start moving as well. Another thing that I sometimes forget to say too, I forgot to say it earlier, if you're not a coffee drinker, I'm not saying you have to start drinking coffee, but coffee can really help move bowels for people. We talked a little bit about the enteric nervous system earlier. Our gut wants to have a bowel movement in the morning. There's a reason why most people tend to have to do that in the morning. So I usually recommend that you can drink a cup of coffee if that's something you're going to do. But in addition to that, try to sit on the toilet and have a bowel movement in the morning if you're able to, because that enteric nervous system really wants to have a bowel movement then too. So I know. So for exercise, it does do a lot. I can't say that it's going to do 10% improvement, 50% improvement, but it does really help a lot with the non-motor symptoms and with the disease in general. Oh, thank you. Yeah, Judy, it looks like you're responding to this question here. Is
Yeah.
that okay?
But the next question is, can you please talk about why sleep problems are so common with adults who have PD?
Yeah, so PD is Parkinson's disease. So for why is sleep so common? So in part, again, there's a number of reasons why sleep is disturbed. So in part, just having Parkinson's disease causes the sleep disturbance, just having less dopamine. I don't know why that's the case, but in addition to that, there are aspects of the disease that are going to make it more difficult to sleep. For one, it causes these different diseases or parasomnias of sleep. So when people have REM sleep behavior disorder and they're having nightmares, they're more likely to wake up and either injure themselves or somebody else. So they're more likely to be woken up. People with Parkinson's disease, if they have the stiffness or pain that Parkinson's disease can cause, it can be harder to fall asleep. If you have restless leg syndrome, it's going to be harder to fall asleep. So in addition to having a disease that makes people have interrupted sleep, it also causes these other physical conditions that are going to occur, which can make it less likely to have a easy sleep. I don't know if I think I answered did I miss anything? I hope I answered your question.
So here's a question that just came in, and I'm not going to know whether I can pronounce this word. Your thoughts on GLUTATHIONE treatments, medications, infusions, and also B1 therapy.
Okay. So glutathione is sort of like an antioxidant. I'll be honest, I'm not too familiar with its use in the setting of Parkinson's disease, so I don't know that I could safely or expertly answer a question on glutathione and the use of Parkinson's disease. B1 therapy, so vitamin B1, so we have a lot of different vitamins that are part of our diet normally. The vitamin B, there's several different B vitamins. B1 also goes by the name thiamine. In general, most people get enough thiamine in their diet unless they are having difficulty with absorption due to maybe a previous bariatric surgery or a change in the way that the gut works due to another disease. In addition, though, most of the time people get enough vitamin B1 just in their diet. The real condition that we'd want to be aware of for people having low vitamin B1 is when people are drinking a lot of alcohol and maybe not having a normal diet because of that. So typically in people with like a disease like alcoholism, for example, and that will cause a reduction in vitamin B1, which tends to cause other neurologic conditions, things like Wernicke's encephalopathy and Korsakoff syndrome. And that's pretty unrelated to Parkinson's disease. They're kind of different parts of the nervous system that we focus on. I'm not familiar with vitamin B1 playing a role at all in Parkinson's disease, though obviously if it is an abnormal level, it can cause other neurologic problems, which should definitely be addressed. I think you said glutathione and vitamin B1. I don't know if there was any other parts of that question that I missed. Okay.
No, I think that was it. You've already spoken about the effects. Well, can you speak about the effect of physical activity and exercise on function and longevity of people with Parkinson's? But I think you've answered that.
Yeah, I hope I did. But I would say, yeah, I always say it's kind of the best medicine is that aerobic exercise. That's not to say that it replaces medicines, but everyone with Parkinson's disease, if they are able to, should be doing some form of aerobic exercise.
So
Not always possible.
I know someone who's had Parkinson's for 29 years,
Mhm.
and he's been exercising vigorously for all of those 29 years. And he says exercise is medicine without being in a bottle.
Yes, yeah,
So,
I know. Yeah, it's amazing.
what is the typical life cycle of the 5 phases of Parkinson's?
Oh, okay. So probably we're talking about the Hohn-Jaeger scale. I'll be honest. So a lot of different, I'm sure different neurologists and different movement disorders providers will feel differently about that. So I hate breaking it down into stages. I know that's not the answer you're looking for. Again, everyone's disease is unique to them. So to break it up into 5, 4 or 5 different categories, I usually tend to think of things more in general as there's earlier stages, middle stages, and late stages of Parkinson's disease. It's going to be unique to the person. Again, no two people are exactly the same. And while a lot of people, about 70% of people with Parkinson's disease will have tremor, that means 30% of people with Parkinson's disease never have tremor, right? That's a huge amount of people. So for me, even just talking about one of the 4 main motor symptoms, when there's such a big difference there, it's hard for me to tell somebody exactly what they're going to look like in different points of their disease. But in general, the pattern you can think of is most people experience a certain amount of non-motor symptoms that we talked about. They're going to experience some slowness of movements, bradykinesia, and one of these other things, whether it's a gait or postural instability, like shuffling of the feet, tremor, stiffness or rigidity. And those things are going to get worse with time. And sometimes there'll be even more symptoms that come along as the disease goes on. Sometimes when people have had the disease for a very long period of time, or for whatever reason, their disease progressed faster than it may have otherwise in somebody else, the disease can become so severe that people will have a much harder time taking care of themselves, especially if they're having a hard time moving, or if they are having more severe forms of dementia, or having really severe forms of psychosis like hallucinations. It can become very difficult for people to take care of themselves. It can be difficult for them to even swallow on their own. And they may need some form of assistance with things like that as well. That doesn't mean that everyone's going to have a disease that leads them to that exact point, but it's certainly a possibility compared to maybe early on, where people are living relatively normal lives with a small amount of medicine and going about their day, maybe are just a little bit more constipated, versus in the middle where they're having a collection of some of these symptoms and maybe it's a little bit harder to do things that they used to be able to do, versus something really late in the disease where they may need a lot of help or assistance, and may even need to live in somewhere where they can get that kind of assistance, whether it's an assisted living facility or a nursing home. Again, that's not true for everyone. Everyone's going to be different.
Here's another one. I'm not on meds yet. I'm active and I exercise regularly. My main symptom, besides a right side tremor, is chronic constipation. Is there a particular medicine that would be less constipating for when I need it?
It's a good question. Everyone's going to respond to medicines differently. Um, my suspicion is if you're not on medicines now, and you will be on medicines at some point, let's say, then something like carbidopa levodopa tends to not really cause too much constipation. For some people, it may cause a little bit of constipation. For some people, it may actually help with constipation. Um, there are some medicines that can worsen constipation, and those are usually medicines that help manage non-motor symptoms. So things like antipsychotics can be constipating, and things like that. Um, they're in general, depending on, it kind of depends on what medicines we're talking about and for what symptoms. In general, with motor symptoms, though, carbidopa levodopa is still kind of the gold standard, and starting on a medicine like that, I don't think that would cause much in the way of significant worsening of constipation. But again, keeping in mind that it's not cheating to be drinking water, but be having fiber in your diet, or even just having something like a stool softener or a laxative when it's needed, right? Nothing wrong with using a medicine like that. That's what they're there for.
Is aphasia associated with PD?
So that's a good question. So aphasia is a condition in which the language center of the brain is not working the way it's supposed to. So specifically, it means that people are having difficulty producing language or difficulty understanding language. And usually it affects, nobody has, you usually don't get somebody who only has difficulty producing or only has difficulty understanding. Usually there's a mix, and you kind of get like an aphasia that affects all of language. So aphasia is something that classically we see in things like strokes, which are not related to Parkinson's disease. There are different types of dementia that can occur, which can cause aphasia. Certainly Parkinson's disease can cause its own unique type of dementia, which is the Parkinson's disease dementia, where word finding difficulty can become more of an issue. But while I would say that's part of the dementia, I don't often think of it as a type of aphasia per se. It's not that it may be possibly a very mild type of that, but it's not the classic other forms of aphasia where somebody has had a stroke or has a kind of a severe variant of something like Alzheimer's dementia or frontotemporal dementia, where may have something called primary progressive aphasia, where specifically the language centers of the brain are the most affected part in the dementia. And I usually, that is not something that happens with Parkinson's disease. It's a separate thing altogether.
Okay, here's another one. Since I've been on my Tori, I've had breathing issues. My breathing is so rapid that I cannot talk or exercise, and I'm totally drained. It's daily now for hours at a time, and I wake up at night. Please advise, this is no life.
Okay. So Rytari is a type of long-acting version. It's a brand name of a long-acting version of carbidopa levodopa. It's the way the medicine is formulated is a little bit different, and the idea is it's supposed to be longer acting, stays in your system for longer, and is may have fewer peaks and valleys that people get with just regular carbidopa levodopa. And I'm sorry that you're experiencing these symptoms that you're having, especially with breathing. It's a little bit hard because I don't know you personally, so I don't know other things that are going on, other medicines, things in your care that could be affecting this as well. And I usually recommend starting by talking to the providers taking care of you, whether it's primary care or your neurologist, to more specifically be able to help manage that. Because just right now, I don't know enough about you, your medical history, or how the medicine could be affecting you to advise you appropriately. Unfortunately, I'm sorry about that. But I would definitely, if you're having breathing problems, I would definitely speak to your doctors. And if it's to the point where you really can't breathe at all, you need to go to the emergency department or an urgent care, certainly.
Are there any new ways to stop tremors? Although I've been approved, I'm not quite ready for DBS.
So DBS is short for deep brain stimulation. It's one of the types of neurosurgeries or brain surgeries that we offer for some people with Parkinson's disease. We didn't really talk about, I didn't really talk about that at all. I just kind of alluded to it briefly, because when we're talking about it, it's mostly in terms of treating motor symptoms like tremor. There are different reasons why people may or may not be a good candidate for something like deep brain stimulation. In terms of tremor, the medicines haven't changed so dramatically recently to focus specifically on tremor. And there are instances where tremor does not respond well to the medicines that we would normally use and in those cases, sometimes deep brain stimulation is a really good choice for treating the tremor. In your particular case, I don't know. I don't know for sure your history with the disease and other things going on. So I wouldn't be able to say one way or the other. And some of the medicines that we use specifically to try to treat tremor when the normal medicines aren't working come with a ton of side effects. They worsen things like confusion, memory, hallucinations, cause urinary retention, can cause dry mouth, things like that, right? And the older we get, the more susceptible we are to side effects from medicines like that. But unfortunately, there haven't been a ton more of newer medicines that are specifically designed to treat tremor.
Okay, what are your thoughts on Parkinson's as an autoimmune disease?
It's a good question. So an autoimmune disease is a disease where our immune system, which is sort of the body's defense against illness, like specifically diseases, right? So that's our immune system. An autoimmune disease is when that immune system starts to attack certain parts of our body mistakenly. It does it by accident, and it can cause a problem. So there are a lot of autoimmune diseases because if it's a part of your body, your immune system can mistake any part of your body as an invader that it needs to hurt, right? So rheumatoid arthritis would be a really good example of an autoimmune disease where our body's immune system is attacking our joints. Or there are gut diseases, ulcerative colitis and Crohn's disease, where the immune system is attacking different parts of the GI tract. Multiple sclerosis would be a neurologic condition that most people think of as an autoimmune disease, where the immune system is attacking parts of the nervous system. With Parkinson's disease as an autoimmune disease, I suppose it could be possible that there is certain instances where the immune system could attack the dopamine parts of our, the dopamine brain cells, for example. I'm not familiar with that as a current theory. We do know that things like alpha-synuclein, that abnormal protein, is getting deposited in cells like that and killing them, and that has been well studied. That would not be an immune, that's on the molecular, when we're talking on the molecules that are happening, that molecular process is not an immune process. It is specifically a misfolding of proteins. And then those proteins going where they're not supposed to and injuring that part of the brain or the body. I don't know specifically of an autoimmune condition which mimics or causes Parkinson's disease, although I suppose it's theoretically possible. I'm just not familiar with that. If that's the case, the way that treatment would work would be much different, because you'd be targeting, in that case, the immune system as opposed to some of the other things that we were talking about. And I'm not familiar with any medicines that are currently approved for addressing an autoimmune pathology, so an autoimmune cause for Parkinson's disease.
If levodopa stops working, are there alternative medications that are options?
Yes, that's a great question. So, the first question is levodopa working at all, right? So if for some reason carbidopa-levodopa is not treating the symptoms, then it will make us ask the question, does that person really have Parkinson's disease, or do they have something that looks like Parkinson's disease but isn't, but doesn't respond to carbidopa-levodopa? So that's the first question. But let's say the carbidopa-levodopa really is helping, right? And the diagnosis of Parkinson's disease is clear, and now over time, many years, right, more and more brain cells that make dopamine start to die and disappear. So people need higher and higher doses of carbidopa-levodopa. In those cases, I would argue it's not so much that the levodopa isn't working anymore, it's that people may need such high doses that that tightrope that we were talking about that we walk gets very difficult to walk, where having even slight adjustments where the medicine is just a smidge too low or a smidge too high, people can start to become very sensitive because they need either so much of the medicine and not enough is makes the person really rigid, and too much they're very dyskinetic and moving all over. Usually when we're that far along, we've already started other medicines that I kind of glossed over or have spoken about, neurosurgical options as well, which can reduce how much medicine somebody may need to take to make it so that the medicine is more useful when you need it. It's not always available for everyone. There's very specific criteria that need to be met in order to be a candidate for things, different surgical options, whether it's deep brain stimulation, have a surgically placed tube into the gut, which can deliver like a gel version of carbidopa-levodopa. I know I didn't totally answer your question, but I would argue that either the levodopa does work or it doesn't work. And in Parkinson's disease, it almost has to work. It's just a question of, is it still working the way we want it to or not? And then at that point, that's when we start, along the way, we're talking about other medicines that can help carbidopa or surgical options. So I think I hope I answered that question.
Do you have many patients with shortness of breath or anxiety attacks?
Yes. So anxiety is common in Parkinson's disease. Obviously, anxiety is common outside of Parkinson's disease as well. And people could have had anxiety before they were ever diagnosed with Parkinson's disease. And certainly having Parkinson's disease can make anxiety worse. And it's one of the non-motor symptoms that we try to treat. And that can come from a number of different therapies. Sometimes it would be an anti-anxiety medicine. Sometimes doing things like therapy, working with a psychologist or a therapist can help with that. Sometimes following with a psychiatrist to also help adjust some of those anxiety medicines can also be helpful.
Okay, we're almost at the end of our time here, but what integrative or alternative approaches are available to address non-motor issues like sleep, insomnia, and or energy management?
Yeah, well, certainly one of the things that's very nice, not just for motor symptoms, but for non-motor symptoms, can be things like physical therapy, occupational therapy, speech therapy. These are things that are going to help with not only with exercising, but for example, an occupational therapist may be able to provide resources and information on how to help manage things like cognition, sleep, things like that. So if we're talking about integrative in that way, working with other specialties like these therapists is a big help. Sometimes it may involve getting another specialist involved, like maybe a sleep specialist, somebody who may have additional forms of therapy they can offer in people with sleep problems, right? They may, sometimes people need a sleep study to get more information. So in terms of integrative in that way, it would be more along the lines of having another group of specialists help. I don't know if you're talking about specific like medicine or surgical therapies. I don't know if I necessarily have an answer for that, but getting other specialties involved can be very helpful with some of these things like sleep.
Okay, I think last question, and I think you've already answered this, but does every diagnosed patient with Parkinson's develop symptoms at the same rate? In
No.
other words, right.
Yeah.
In other words, does everyone with Parkinson's progress the same?
No. So like I said, this is probably one of the most important things to think. I know there have been a few questions about progression, but probably the two most important things about progression of the disease is that the disease is different for everyone because everyone's different. And aerobic exercise is the best way to slow down the rate of disease progression. Those are probably the two most important things to say about disease progression. And unfortunately, there's not a great way to predict how somebody is going to progress. But I usually say that, when I'm seeing somebody, the first few times that I'm seeing them, I get a sense of how they are progressing. And people tend to progress at the rate that they're progressing, which I know is kind of obvious. But right, if somebody, from first time I see them here, and then 3 months later, I see that they're about the same. 3 months after that, they're still about the same, maybe just a little bit changed, right? They're probably going to progress at that rate where they're not going to progress very, very fast. But if somebody's progressing, a little bit faster, not like very fast, but the next time I see them, they're having a little bit more trouble with sleeping, and the time after I see that, the sleeping may be even a little bit worse, or time after that, their constipation is worse. Maybe they are going to progress a little bit faster than the first patient I described.
Okay, that takes care of the questions. I want to thank you very much for this evening.
You're
I
welcome.
think
Thank
it's
you for having
been
me.
informative, and I hope everybody got all the, well, I mean, we answered all the questions that I got anyway. So thank you again. And everybody, this is being recorded and it will be available on the website in what, Michael, about 2 days? 2 days. He's nodding and giving me a thumbs up. So 2 days it'll be available on the MAPS website. So thank you again, everybody, and good evening.
Thank you. Thank you for having me.
Thank you.